brand versus the generic brand. There are a lot of patients now taking generic rather than this innovative brand. So how often you see patients with benefit of those molecules and complication of those molecules in your routine practice?
I think the major difference one must understand is mostly in the pharmacokinetic. The raw materials, people keep on mentioning this. The raw materials are same, but then when you have a brand, for example, when enoxaparin was marketed in the world, the way you get the active form of enoxaparin goes through a really polychromatography, many phases. So the kinetics become different. For example, when you have an innovator brand, you know that the molecule is supposed to act for 12 hours and then you give a BD dosage. So molecules like that where you're worried about bleeding and things like that, it makes a huge difference because the kinetics might different. The sequencing, all that they have is the raw material. They probably have only patented few of the steps which will not come out. So that's one worry. Exactly the same thing when you have a ticagrelor. But then molecules like this where, on a day-to-day basis, when you have a patient on a stent and then ticagrelor, I would always prefer the innovator as far as possible. Somebody could afford it. But again, like I have shown in my talk also, one of the things with Arni also, Vimada is such a wonderful drug. But the problem is the cost factor. So, something is better than nothing. So there, instead of 100 milligram, maybe 50 milligram of your, they may be equivalent to the 100 milligram. I don't know. I cannot really. But then, so in that context where it's not really going to be a problem in terms of bleeding or some of the, I would prefer the generic brands. What do you say?
This is a difficult question to answer because our patients comes and ask, sir, can I buy the drugs from Janaushadhi? Is there a difference in the quality? I'll tell them I do not know.
No, that I can vouch because I've been following this, tracking this very, very frequently. What I tend to see is that the easiest thing is cholesterol. If somebody is on a because that is the only area where you're controlled because sugars might vary. Somebody is very stable on atorvastatin 40 milligram, 130. Next time when he comes on a visit, it's gone up to 230. Then you know that that is happening. And this has been I think that probably the main message comes from other physicians in town as well. So that's the only area where we are very sure.
We are finding difficult when there is oral anticoagulation about. Lot of INR difference between this.
WARF.
Yes.
Yeah.
Sir, what's your advice on vaccination, sir, for regarding influenza and pneumococcal vaccination?
I think Jabi is the right person to answer that. He did a trial on that.
Yes.
We had a trial across, it is a world trial, including India. We could not find actually much difference. But those people who were vaccinated during the season, they had a benefit. Otherwise, there was no remarkable benefit. But there are certain data which shows that there is some benefit when you could cut down the infections. Now, it's a class 2B recommendation using vaccination. So, at any time, I would prefer to give vaccination if the patient can afford.
I think I have two comments to make. One, actually, the main author of this paper was Ambuj Roy from India. So he is convinced beyond. In fact, this topic was given to him. I did give him as a talk also. So these people, they have the data to say that this is definitely helpful. But though it's not become there is a recommendation to use vaccine. But I think going one step further, when you find, for example, the seasons, this is probably more relevant in the Western countries, but then even in India also during the cold months, if you start looking at the CRP levels, and you find that the CRP levels, I'm talking about HSCRP, not the usual CRP, and if you find that these levels on the higher side, there is an infection which is going on. And today, both of us are into another trial. This is again another global trial where we have gone one step further. How do you bring down this HSCRP? It is actually the infection. So you can prevent that by using a vaccine. Number one, that's your question. Or you can go one step further, use monoclonal antibodies. So there is a new drug called siltevecumab, which both of us have done about 15 patients altogether. So this is a drug which has been shown during COVID times to reduce the HSCRP. So there are a lot of indirect evidences, and today the recommendation is to give a pneumococcal, I think the vaccine, the influenza. So I think all heart failure patients, and most of them, they succumb because of coexisting infection towards the end of the heart failure status.
The group I meticulously following this vaccination recommendation is the pulmonologist. Though there is recommendation for diabetes, COPD, and also for heart failure.
Sir, with respect to SGLT2 inhibitors, is it advisable to start at a lower dose and go upwards, or to start at a maximum dose at the upfront?
I think there is no doubt. This is only drug and MRI which you start at the accepted dose, 10 milligram. Because this is, even in a non-diabetic patient, it's found to be safe. So you start with 10 milligram. There's no need for a 5 milligram. MRI also, you start with 25 milligram valdecoxon. If you find that there are few patients where the potassium might go up, in that case, you can even bring down to 12.5. It's again not the dose which is important. It's the way they prevent the fibrosis. That is the main role for MRI.
In fact, this 5 milligram dose has never been tried in any of the clinical trials. And that's the beauty of SGLT2 inhibitors. The beginning dose is the final dose, no titration.
But I think there's also a very important factor in your question, because EMPA, if you looked at it, it is not 25 which is tried in the trial. It's 10 milligram. So by the same logic, 5 milligram should work. But this I have asked, in fact, Professor McMurray also, we asked this question. So why not 25 milligram? So is it 10 is good enough? And again, Dr. Lawrance showed a slide. DAPA is effective in the only drug which has shown a mortality benefit is DAPA, not EMPA. So was it because they were on 10, the EMPA was on 10? So now there is a trial where they're trying to hike it up to 25 and see. But the official explanation from the people who did the trial is that the EMPA had sicker patients, and that is probably the reason why they did not show the mortality benefit. 10 milligram, 10 milligram, 10, both 10. EMPA and DAPA both 10. No, both. Heart failure, it's 10. The drug was used at a dose of 10, and 10 is recommended. But EMPA 10 is enough. For diabetic control, you might need 25, but 10 is enough for EMPA.
It's possible the more dangerous is both the ticagrelol and the oral anticoagulation, which is very harmful with this generic. Yeah, and low molecular.
My question is, see, a good number of people in the cardiac failure die of arrhythmias, ventricular arrhythmias. Is there any role for antiarrhythmics as part of treatment? And the second thing is clot formation in the LV. Some of them can be very well documented by the echocardiogram. Others, is it any role for anticoagulant prophylactic anticoagulants forms part of the treatment for cardiac failure?
A patient without atrial fibrillation and no LV clot at the time when you do or an in-text echocardiogram, there is no indication for prophylactic usage of anticoagulation. But if you come across a clot, then you have to use anticoagulation. And for an LV clot, the data is all for vitamin K antagonists. The data is sparse for NOACs. But we all use NOACs. Data-wise, it is warfarin. And second thing is, one situation where I may start prophylactically is if the patient has a spontaneous echo contrast in the LV, I may start on an oral anticoagulation. The oral anticoagulation is pretty difficult in these heart failure patients because they are on multiple drugs.
I think so I think the question is, there is no doubt when you have a large anterior infarct and an LV apical clot, atrial fibrillation, I think the way to go about is, number one is warfarin. But then there is also a trial which is conducted today. This is a trial which has been followed up with apixaban and even in LV clot, and they found that over a period of time the clot burden comes down, it comes down. But then it's not there was a trial called Commander trial in where they used dabigatran in heart failure, and there was actually no difference in mortality. So routinely using this Commander HF, routinely using this is not indicated in. No, I'm talking about anticoagulants. Now, coming to the antiarrhythmics, I think the best data, if the sudden cardiac death is brought down by two agents. The best is beta blocker. Higher the dosage of beta blockers, the better the reduction in mortality. So, second important drug is ARNI again. In fact, many patients, what they've seen is patients who are candidates even for CRT. You start them on this, the Vimada group. it comes down. The LV improves, and then there is no need for a CRT, and that essentially translates into. But then I think I'm sure Lawrence will be able to answer that better. But sometimes you pick up ventricular arrhythmias very frequently. Somebody comes to your clinic, and then when you put them through a Holter, then you have monomorphic or polymorphic tachycardia. Then it becomes a different game. I think then it becomes Lawrence headache.
So regarding anti-arrhythmics for heart failure, I think when you look at anti-arrhythmics, we have to look at two parts. So the true anti-arrhythmics, which are beta blockers or amiodarone, which we use most in heart failure. Other anti-arrhythmics, like all other heart failure drugs, including ARNI, including ACE, ARB, statins, all have shown benefit in reduction of sudden cardiac death. The reason being the remodeling. So one of the major contributor towards arrhythmic substrate in a heart failure is remodeling. When you have to have a lesser fibrosis, lesser negative remodeling, you tend to have a better arrhythmic outcome. That's the one way by which most of these drugs are able to deliver. And among these drugs, one drug which has delivered extremely good was ARNI, which was 20%. See, the 20% antiarrhythmic risk reduction was close to what beta blocker delivered. In double digit, the only other drug which could deliver double digit reduction in sudden cardiac death reduction was beta blocker. So next drug was ARNI. So it had results more and above the remodeling effect. So there are, when you look at paradigm data, they have looked at ICD shocks. They could see a significant reduction in ICD shocks when patients are started on ARNI. So I think when you treat heart failure as a wholesome, you look at heart failure as a whole disease, the drugs which you, whatever you are going to give to create a good remodeling effect on heart, they're all going to be antiarrhythmics. So you may not require an antiarrhythmic as a separate entity until unless you have a documented ventricular arrhythmias. In that case, antiarrhythmics will not suffice. You may ultimately end up putting a device, because these are the high risk patients for a ventricular arrhythmia. So these patients will require more than antiarrhythmics. So role of antiarrhythmics is very limited. So if you find out an arrhythmia in these group of patients, you are going to put an ICD. Post ICD, if the patient is going to have a recurrent shock or recurrent event, then you are going to use an antiarrhythmic. Otherwise, very limited usage of antiarrhythmic. Prophylactic, we don't use antiarrhythmic. The only antiarrhythmics is beta blocker, maybe.
No, but what about the CAMIAT and the EMIAT trial? This is where amiodarone had really shown a benefit in terms of reduction of ventricular ectopy. Of course, flecainide was one drug which has shown excess mortality, but this is CAMIAT and EMIAT showed that amiodarone is useful.
Both are secondary prevention. Both are secondary prevention.
True,
the problem
in a patient with heart failure. Mostly these are all ischemic heart disease patients.
Yeah.
So in that context, is there a role for antiarrhythmic? That's a question.
No, the problem is like most of the secondary prevention trials, when you have a proper ICD trials, the role of primary antiarrhythmics for a primary prevention for ventricular arrhythmias were not good. They either had a worse outcomes with other antiarrhythmic agents, maybe a neutral outcome with amiodarone. So they could not show a significant benefit with prophylactic antiarrhythmics. So when you have an arrhythmia, yes. The problem with arrhythmias in heart failure is the moment you are going to have a heart failure arrhythmia, you are going to put an ICD. Once you put an ICD in, the drug which you usually upregulate or uptitrate is beta blocker. You go on a high dose beta blocker. If a patient develops an arrhythmia on beta blocker, then amiodarone comes in. And ultimately, it will be a very low dose amiodarone in most of the patients. We don't use amiodarone also for a longer period of time. So the first thing I do after putting an ICD is take out amiodarone. So if a patient is already on amiodarone for arrhythmia, the first thing I do after putting an ICD is pull out amiodarone and keep only on beta blocker.
And one of the problems that you see, the patient has an ICD and the patient is on amiodarone, they come to you with a very slower VT then where the ICDs won't shock also.
So amiodarone will create a slower circuits, and these slower circuits have to be ablated. And I think with improvement in heart failure management, the arrhythmic load is definitely coming down. And heart failure, you all know that heart failure, the primary people who are going to have a heart failure, like arrhythmic deaths, are stable heart failure, 1, 2. So 3, 4, class 3, 4, NHA class 3, 4, they are mostly going to die of a heart failure. And the arrhythmias, what you are going to see in class 3, 4 heart failure are end stage arrhythmias, where you are not supposed to intervene. That's the reason, if you look at ICD indication, ICD is not indicated for a patient who is on class 4 heart failure. If you have a patients with severe LV systolic dysfunction and you have a documented ventricular arrhythmia, but patient is class 4, putting an ICD may be problematic until unless you plan a CRTD on him or a transplant on him. Otherwise, preventing these arrhythmias are end stage arrhythmias. Here, really, you are unlikely, you are most probably going to make that patient's death very painful. So, because this device is going to shock all the time. So, in a class 4 heart failure, they allow only to put ICD only when you have indication for CRTD or a plan for a transplant. So, otherwise, you don't put an ICD also. That shows that your heart failure management is more important than arrhythmic management in most of the patients with heart failure. Okay, sir. So, with this, we'll close the discussion, and let me invite Dr.